Welcome everyone to today's webinar, Bridging the Last Mile, Getting Actionable Data to Physicians to Drive Optimal Performance and Revenues. I'm Emily Rapley with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. As a reminder to our audience, today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Stephanie Kovalik is the Chief Strategy Officer at Sage Growth Partners. Stephanie is a leading healthcare authority and expert on payment reform, population health, reimbursement models, revenue cycle, and clinical workflows. As Chief Strategy Officer and GM of Market Research and Strategy at Sage, Stephanie sets the direction for the firm and leads its market research and strategy work. Stephanie oversees the firm's strategic work for its health IT, investor, payer, provider, and med tech clients. Before joining Sage, she brought her expertise to the Tufts Health Plan and the Johns Hopkins Health Plan, IDX Systems, GE Healthcare, and Availity. Joining Stephanie today is Dr. Doug Mitchell, who is the Chief Executive Officer and co-founder of Adfinitas Health. Dr. Mitchell is a board-certified internist who's practiced hospitalist medicine since 1998. As CEO and co-founder of Adfinitas Health, he sets the strategic direction for its hospitalist leaders, practitioners, and operational teams. Doug has created innovative quality initiatives and embraced value-based care from the company's inception, and has improved core measures, quality metrics, and patient satisfaction results for clients, and saved millions of dollars for Adfinitas' hospital and post-acute partners. His previous experience includes a residency in internal medicine at Walter Reed Medical Center and public medical service in the Indian Health Service, as well as serving as the head of hospitalist service and medical staff president of Anne Arundel Medical Center. He also earned his MBA from Auburn University. Joining us today is also Chris Heggie, who's the head of product management at Ingenious Med. Chris heads up the product management team at Ingenious, where he supports several functions, including pricing strategy, go-to-market management for product releases, client enhancement requests, and the analytics and reporting function. Before coming to Ingenious Med, Chris held a variety of roles, including wireless strategy and business development at AT&T, identifying energy efficiency initiatives at the Environmental Defense Fund Climate Corps, and R&D test engineer with the U.S. Air Force. At this time, I'm pleased to turn the floor over to Stephanie to begin today's presentation.
Thank you, Emily, and thank you all. I'm very happy to be here with you today. To set the stage, I'll just talk a little bit about data. The sheer volume of data in the healthcare system today is dizzying, and it often comes from separate and disconnected systems. From the EMR data to the claims data to the social determinants and patient-reported data, knowing what to do with it is nearly impossible. In some recent primary research that we did as a firm with healthcare provider leaders, the single biggest challenge we found with data and analytics is that there's too much data and not enough insight. All this data should really translate into action and provide physicians with the insights that they need to deliver high-quality care. This lack of ability to really sift through that data surely contributes to the increased feeling of burnout by providers and potentially leads to underperforming practices. Physician practices today face increased regulatory pressures and increased financial pressures. Interoperability between systems continues to be a significant challenge in an environment where data sharing and common views of data are really critical for success. Within their own walls, hospitals and health systems are increasingly more successful at data sharing, but when needing to share and collaborate with others, they don't feel as successful. Measuring the financial outcomes and measuring the clinical outcomes together, that's often a disconnected process and measured in different systems, and this really leads to different views of the data and different perceptions of performance. When you have those different views and those different perceptions, there can be a lack of trust in the data and lack of engagement across all of the stakeholders. As a result, there's a really big disconnect in the data translating into really actionable insights. In a recent survey conducted by Ingenious Med, we explored how physicians view or leverage data. While the majority of them, at 86%, have access to data, only 28% felt that they have enough insight into how that data translates into results around productivity and performance, and the others feel the insights are really lacking. The EHR should really allow physicians access to the data and insights that they need to effectively communicate and treat their patients. However, 68% of physicians say they lack the appropriate staff and the appropriate resources to use the EHR data to its full potential. They can see clinical notes, but financial and quality outcomes often come long after the patient leaves, and any desired behavior change is difficult to address with these really long lags. And so physician burnout is increasingly common in today's healthcare world. I don't think I'd go a day without seeing some article and some magazine or blog or somewhere on the internet that talks about how physicians are increasingly feeling burned out and leaving their profession or thinking about it. According to this study, 66% of all physicians have considered other career options outside of their clinical practice. And this burnout is due to many reasons, and it's clear that the heightened demand for data reporting is contributing to that decrease in provider satisfaction and the joy in practicing medicine. It contributes to a feeling of creating work without seeing the benefit and forces the impossible choice of trading off shift hours or trading off face-to-face time with patients in order to deal with the demands around data.
So we will now begin our first poll of the webinar. This question is, what are the biggest challenges you face in delivering insights to clinicians? The first answer, lack of tools available at the point of care, resistance to using technology, or the data provided isn't actionable. We'll go ahead and give a few seconds here to allow you to answer by selecting one of those options on your screen. And just a few more seconds here to allow you to answer before we see the results.
Stephanie, this is Doug. Should I wait for the survey result or?
No, go ahead, Doug. Let's get started.
Okay. All right. Well, hi. My name is Doug Mitchell, and where I fit in is that I'm the sort of lead person at Adfinitas Health, and we're a hospitalist group, a national hospitalist group, currently in about 15 hospitals and 60 post-acute facilities in 5 states. Founded and led by board-certified docs and continue to be owned by physicians. I think what makes us notable as compared to possibly other hospitalist groups is that we really utilize PAs and nurse practitioners honestly at the top of their license or top of their credentials. I also think the reason I'm here is over the 12 to 13 years we've sort of been providing this service, we've really come to understand the physician and PA nurse practitioner providers as a healthcare workforce that has to be actively managed and has to be given the data so that they can help manage themselves. There's a tendency in healthcare to look at highly trained professionals as sort of being able to self-manage. And we've just really found that that's not the case. That's not to say that they aren't motivated, but if they don't have the data needed to go in the right direction, if they don't have somebody behind them pointing them in which direction to go based on that data, we find that we really just don't accomplish what we need to accomplish. And so my goal here is in the next 4 or 5 slides, just show you how we use some of this data to accomplish the things that we need to accomplish. So next slide. First is a revenue cycle. That's key, obviously, in healthcare with margins being as thin as they are. And having our billing data from our vendor, Ingenious Med, we're able to track several things. First, how long it takes a provider to enter the charge and get it started. And this is key, especially now as more and more providers are employed and work RVU productivity pay is decreasing in importance as value-based care goes forward. There's just not the same incentive to get charges entered. So it's really important to be able to track that. And the data that you get, we can track company-wide, we can break it down by individual sites, we can break it down by individual providers to see who we need to intervene with or who we need to share their data with relative to the group. And then you can also take this data from the back end. So the providers submit it to our office, but how long does our office take then to send it off to the revenue cycle vendor? So again, this is something that helps us make sure that we maintain or are as effective as maintaining the margin that we need to maintain as possible. So next slide. And then when it turns to performance, and this is both us managing the providers and the providers seeing how they perform relative to others. So with having access to good billing data that can be processed efficiently, I can, on a regular basis, generate reports that on individual provider length of stay, both in the inpatient setting and the observation setting. Obviously, I can look at their productivity based on how many shifts they work, how many work RVUs they generate per shift, can see how quickly they submit their charges, and a number of other things like this. And what's important about this is that it allows me, one, to follow the individual sites, but then also to break it down by provider and then share this with the providers so they can see, when, somebody, can't get their charges in and it's, like the provider number 4 here whose charge lag is 3/4 of a day, but they're really no more productive or no more busier than anyone else. You can share this with them and say, help me explain why, explain to me why this is the case. So, next slide. Another thing really important nowadays is compliance and ensuring that our providers are coding appropriately. So what's nice about this data is I can look at my individual providers and I can see the distribution of codes they choose within each category of visit. And that's important for 2 reasons. One, often you'll see providers charging, high-level codes because there's still a work RVU incentive, and you worry about them gaming the system. Now, that may be justified based on the documentation, but it is something you have to be aware of and look at to be sure that something wrong is not happening. Occasionally, you'll also find some providers that, despite education, feel they never want to be audited, and if they charge all level 2s across every category, they feel that that's safer. But again, if I have this, I can show this data to them and say, look, these other people are seeing patients just as sick as you, and I don't understand how this could happen. And the final thing in this is there are certain codes that generate really high work RVUs, and you just want to be sure that your providers aren't gaming the system. So you can watch and see if there are people with high levels of these or with a larger proportion of these high-level work RVU codes. You can go back to them and see if it's really justified or not. So, it works out 2 ways. One, it maintains your compliance, but 2, it also allows you to go back, and if there is someone possibly coding lower than they should be compared to their cohort, it allows you to show that to them and then intervene as needed. Next slide. MIPS and MACRA, part of the Affordable Care Act. This is really key for provider groups. We get positive or negative adjustments to our reimbursement for Medicare based on our performance on these measures. So it's really important for provider groups to be able to track this at a site level, but also at individual level. So you can see 2 things. If there's a provider that has a lot of patients, they're high priority because If they hit 90%, that's a lot more patients in aggregate compared to the group. And then I guess obviously you want to catch those providers that have a significant number of patients but aren't performing at the level that need to perform. So again, you can show this to them and say, most of the other people in our group are able to get 100%. Explain to me why you can't get 100%, and what do we need to do to make sure you do get 100%. So next slide. And when it comes to the other thing, when it comes to managing providers and allowing them to manage themselves by looking at the data, it's really important that you have a database, a charge platform billing database that integrates with other data systems. As it is now, it's still somewhat disconnected. Yes, there's an EHR that has a lot of data, but there's also state databases, the health information exchanges. If you're in an ACO, there's frequently another database. There are some places that have different pharmacy databases. So it's important that you have a data warehouse that can bring in different aspects, and that your billing data is able to be part of that. Because what's important about that, especially in hospital medicine, patient attribution is difficult. Someone gets admitted to the nocturnist, but that nocturnist, even though they're listed as the attending, is not cared for, doesn't really have any responsibility in the care of that 5-day stay for the patient. So it's important that you have a way of attributing the inpatient care to the actual provider that did it. And then what this allows you to do is to go back to the providers and show them the data. So you have a provider like number 3 who has a long length of stay, or I'm sorry, provider 6 has a long length of stay, but has a low case mix index. Because I think most of us who have interacted with physicians know that the first thing they say is, yeah, my length of stay is long, but I see sicker patients. And so this is the sort of stuff that you can then go back and say, well, yeah, but this person has a lower length of stay and their case mix is higher. So again, I don't understand, help me understand how this is. And I will also say what this does for you is not only in the negative, but the positive. You can highlight those providers that have a low readmission rate, low length of stay, but a high case mix, and then they become sort of the examples, and you can get best practices from them in terms of how they manage to affect that care. Next page, next. Oh, the final thing is burnout. It's really important when you're talking about managing a workforce to think about the sustainability of that workforce, and why we're not being paternalistic or looking at how people live their lifestyle. There are indicators that point towards providers that might be at risk of burnout. And really interesting stuff that's in the literature now is noting when providers document in the EHR. And as a surrogate from that, what we do is we use our billing platform, and because we have different EHRs throughout our system, and it's hard to get a huge health system to concentrate on one relatively small physician group or provider group to provide this data for you. But we're able to actually follow when our providers are entering charges. So, if our providers are going home and 50 to 70% of the time they're at home working, putting their charges in, that says to us that something probably may not be working well at that site, that they can't do all of their work during the workday. So this then becomes a way for us to find high-risk sites at burnout. And then, as a corollary, we can go down into the individual providers and see which providers there are, because invariably, even though it may be a site that has a lot of folks entering charges after hours, within that site, there are people that get them in, in a very time, during the workday, and there are people that don't. And then you can also look at both and ask them, especially the people that are getting them, how do you get them in, and how these people don't get them in, and figure out what sort of workflows can be changed to minimize that stress and prevent burnout in all the providers. And I think that's the last slide, so we can go to the next, and the next person can start.
Thank you so much, Doug. We now actually have another poll question for our audience here. So the question is, how would you rank your clinicians' engagement with how their productivity affects your organization's performance? And those will be ranked on a scale from excellent to poor. We'll give our audience members here a few minutes just to answer that question. And we'll give it just a few more seconds here. How would you rank your clinicians' engagement with how their productivity affects your organization's performance? Fantastic. And those answers will be published in a blog following the webinar. Before I pass it over to Chris here, just a quick reminder to our audience. Please submit any questions that you have by typing them into the Q&A box on your screen. Once we hear from Chris, we will open it up for the question and answer session. So Chris, I'll turn it over to you now.
All right, thank you, Emily. So good afternoon, everyone. It's been great. So we've heard from Stephanie, a little setup on some of the research about data availability, and then we've heard from Dr. Mitchell, certainly a number of good use cases on how they use some of Ingenious Med as well as other data sources to help manage their physician workforce. But I'll touch a little bit on some other strategies that we use, but first, just a brief description about Ingenious Med. So Ingenious Med is a healthcare IT solution that helps increase physician productivity and health system performance at the point of care. So we're really focused on the revenue optimization through a number of different areas, particularly the physician charge capture at the point of care via our mobile and web platform, which helps with improved coding compliance and a number of other factors we'll speak about later. We also offer a business intelligence platform for reporting on operational and financial metrics. So this is really what we'll focus on going forward. But then finally, our solution supports the transition to value-based care. We'll touch a little bit on this in a next slide, highlighting a previous webinar that we did. But an overall view is our solution is used by approximately 70% of the nation's largest health systems and physician management groups. And we touch about 1 in 5 hospitalized patients across the United States. So a good breadth of information, so that gives us a lot of capabilities from a data perspective and when we look at it from a macro level from what's available to us. We can go to the next slide, please. So I'll touch a little bit on a previous webinar that we did, and Dr. Mitchell highlighted a little bit of this, as well as Stephanie, but we really feel like our platform is an extension of the EHR. So there's lots of IT solutions that are used in healthcare today. And how does IM fit in with that? So we all know EHRs do a significant number of tasks, right? They've got necessarily broad functionality that hosts a large quantity of clinical data. But our clients really still have a number of pain points, which we solve for them. So first and foremost is that revenue optimization that I touched on. So we support coding compliance through our UX features. Examples include displaying favorites and frequently used diagnoses. We create custom super bills for our customers. And then for newer physician, our master coder provides an optimized coding recommendation engine. So anytime they have questions, we're able to optimize that coding. The second part that we see as an extension of the EHR is really that data intelligence capability. So, like a lot of IT platforms, we've got that robust reporting capability, but we also offer this business intelligence platform to enable the self-reporting creation and the ability to extract and manipulate the data sets within our system. So as Dr. Mitchell highlighted a few of those data points in which they pull information from our system and can combine it or manipulate it within our platform. And then he also highlighted one of the greatest benefits of this data is the availability across all of the hospitals and affiliates and post-acute. So our system really extends across the continuum of care, especially for physician groups and larger hospital clients like Adfinitas. And finally, I'll mention the platform also helps facilitate that transition to value-based care with throughput indicators. We've got BPCI identifiers, and also we're one of the largest MIPS registries in the country. Next slide, please. So when we talk about strategies that we used with this data elements going the last mile, let me highlight a few of these strategies that we've seen enabled by our successful clients, including Adfinitas, as well as other areas outside of healthcare, but still in that dynamic customer-facing environment. So the first is really enabling that data continuity. So Stephanie mentioned there's no end to the amount of data available, clinical, operational, or otherwise. But really, to be successful, you have to have that quality data specific to the behavior that you're trying to change. How do we really distill the noise from all the other information out there? And then how do you achieve that quality data aspect? So it needs to be comprehensive, so no critical missing pieces from outside the hospital. It's got to have every information from other facilities, post-acute care, anywhere the provider is. It really has to combine all that information for a comprehensive view. And then finally, it needs to be normalized for that performance relevancy across all providers, sites, groups, et cetera. Dr. Mitchell highlighted in there, you're always going to get pushback. So how do we make sure this is the most relevant comparison across all of the providers within the system? The second strategy is really delivering that data to the relevant workflow at the point of care. So, solving for goals alignment is a struggle for many industries whose daily workflow are significantly less complicated than healthcare. But those successful organizations realize the importance of inserting data and therefore awareness into the workflow in comparison to those retroactive follow-ups, which are sometimes the best that you can do, but how do we get it really at the point of care, at the point in the workflow that the decision is being made? And I'd also like to note on this slide, as we talk about bridging the data gap and distilling all this information, a more recent development that we're hearing about from more clients is when we talk to them, there's been a significant increase in focusing on AI and machine learning to deliver these insights, really leveraging that investment that we and other larger clients have made in data in the past years. And really, we feel like the capabilities of our mobile applications sitting right in the palm of the physician's hand are really going to add to this. So, how do we bring these AI machine learning data insights into, again, the physician workflow? It's something that our clients are focused on, and certainly something that we're focused on as we look forward. Next slide. I'll talk a little bit here about our data approach. So we had mentioned some key strategies before in the previous slide of what other organizations do. Really, our lens as we look at the approach that we take when we're facilitating this data transfer is really how we view the data elements and create and display for our clients so they're able to leverage it across their entire enterprise. So I'll start with reliability. So it's the backbone of any data distribution initiative. And so when I'm talking here about reliability, I'm not necessarily speaking from a technical perspective, but from a trust perspective. So Dr. Mitchell highlighted this again. One erroneous data point can crush physician confidence in the source and therefore the message. So our charge and billing data is unique to the platform and based on end user inputs. So no matter where they're providing care, this kind of provides or allows robust comparison when you're talking about site-to-site comparison and certainly across providers. Second is timely. So with the upcoming release of our dashboards, we're providing access to data from the last day to the last year, really, one click away from the primary workflow. So it's got to be there. The data's got to be available right when the clinician's making that decision. And having that reliable information at the right time enables that information to be actionable at the point of care. So again, we talked about the next decisions being made, knowing where the user stands within the context of the broader business. And also, I like to note here, so while this approach works well with what you think of as kind of the typical data analysis with multiple aggregated items, and maybe a historical trend, it also works really well with those simple indicators. such as our potential missing bills functionality, and flagging on the main census page. So this lets clinicians know immediately that there's a readmission, maybe a bundled care patient or a high-cost patient, and can really drive an appropriate decision right at that, right on their mobile device when they're putting in their charges and making those decisions. Next slide, please. So I talked about our robust data platform. So we've got what we call our IM analytics platform. It really consists of 3 elements. So our soon-to-be-released persona-based dashboard, a large topic of curated reports, and then our full-service BI platform we call Advanced Analytics. So all of these offer really an increasing level of detail depending on your needs, going from a quick view to, again, those pre-populated reports that you can go and grab, all the way into what we would consider more of the data analyst role that wants to dig around in our full-service BI platform and maybe do an extraction. And so for this presentation, I'll just touch more on the persona-based dashboards as we talk about bridging that last mile. As we looked at the last mile strategies our customers are trying to drive and the data approach our platform enables, consolidating our data and making it available one click away from the primary workflow made the most sense to us. So we've created these 2 standardized dashboards. It would be the landing page upon clicking at the Analytics tab in our primary navigation window. So again, really, it's that one click away from the primary workflow that the clinicians are doing on our web environment. And really, we expect this to better engage the clinicians across the personal and organizational performance when they use the application, and not that retroactive look back that I know a lot of us are always working towards. So the provider dashboard just offers those data visualizations across 9 KPIs, group and individual, for volume, readmission rates, revenue capture, productivity, and utilization, including the length of stay and readmission. And then there's also a click-through ability, which I'll drill down into the next slide. The administrative dashboard is really for site administrators to better manage their location. So it consolidates that information previously only available by cross-referencing a lot of reports that we've got. And the administrative dashboard includes data visualizations on 16 key financial and operational KPIs. It really summarizes the overall business direction. Those include, when we talk about some volume, utilization, and then coding distributions across their groups, as well as billing timelines that Dr. Mitchell mentioned. And one note, so while we've kind of enabled the ability to create a customized dashboard elsewhere in the BI platform, some of our largest clients really highlighted that standardization as an important part of their data strategy. So, letting everybody select what they want to see is not something that a lot of administrators have talked about. They really want that standardized view so that they know all of their clinicians, all of their physicians are on the same page and they know exactly what they're seeing. So they feel this is a kind of a key to the performance, and we've enabled that. Go to the next slide. And finally, I'll just mention, we'll take a look at the drill down available within the provider dashboard. So on the last dashboard, we've got click-through links that can really drill down into each one of these. So this one is focused, that we've shared here on the screen, is the provider dashboard. It's focused on the charge capture, rather, within 24 hours. So it's got metrics that you probably expect to find, but also something clients have continually asked for, which is a view to compare to other physicians. I find it kind of interesting, and we talked with Dr. Mitchell before this about how he does these comparisons. It really is that transparency that lets everybody know where they stand. So it's kind of an interesting anecdote. So our 3rd most run report, after just a general list of bills in our enterprise summary, is named provider comparisons. And typically that's only available to site administrators. What we're doing is enabling that transparency to the providers. And, you know, with any time you've got this transparency, what we're expecting is that sort of self-correcting, just understanding where certain providers stand within the group. And you really got that relative performance. So you can have those conversations to bring in outliers, and then the group as a whole can sort of march towards either the middle or sort of the higher performing with the understanding of where they're at. And really this opportunity, these one-click dashboards also enable further alignment with the organization as we think about increasing feature sets. So for instance, we're reviewing how to allow administrators to set up visual group targets. You can use simple color coding, and you can also just incorporate that best-in-class benchmarking at a national level, which is something we're looking at, and then threshold notification triggers. So once somebody gets to a certain threshold, you know, do they get a little ping on their mobile device, and how do we enable, you know, the kind of wishes of our clients and the things that Dr. Mitchell is trying to push to the rest of his organization, you know, really at that point of care. And with that, I'd just like to leave everyone with one final takeaway that we talk about is really that best way to drive performance is using the tools that you've got to push information where the decisions are being made. So it's really pushing that information immediately to within the workflow to change those behaviors, and you really get those benefits of the behavioral economics out of that information right when people are making those decisions. So with that, I'll hand it back over to our moderator, Emily.
Thanks so much, Chris. So we will now begin the question and answer session. A quick thank you to Stephanie, Doug, and Chris for that insightful presentation. As we begin the question and answer session, a reminder to our audience, you can submit your questions by typing them into the Q&A box on your dashboard, and we will try to get through as many questions as we have time for today. It looks like we already have some questions flowing in here, so let's go ahead and dive right in. This first question is about those dashboards. So we have an audience member who asks, are these the only two dashboards that we receive, or can we make our own as well? Are they customizable on our end?
Yeah, so that's a good question. Obviously, I'll take that one. So right now, these are the two personas that we focused on. So it's really that site administrator and then any physician. There are some other dashboards that we're exploring, and as we see kind of the applicability and what other clients want. And they're static right now, but I really want to focus on the feedback that we got when we talk to clients. Is I want one view to look at so that I know that everyone within my group or my site or my entire unit is seeing the same information. So we've enabled the ability to make custom dashboards, but they're not shown on that current screen. And there's a little bit of thought behind that to just make sure that that view is consistent. And as time goes on, I suspect we'll get other inclinations and customizations with clients, and I think we can entertain that. But right now, that was the logic of having these two views.
Perfect. Thank you so much for that clarification there. So this next question is about how value-based care is all about reward for quality care at a fair cost. So the essence is a risk-based portfolio management for human health. This question is, how do you see this impacting EMRs, billing systems, and analytics?
Emily, was that one directed towards anyone?
Not in particular. If anybody wants to dive in and start with that, I can repeat it real quick. It's how do you see this impacting EMRs?
No, go ahead. I was going to ask you to repeat it. I'm sorry.
No problem. So the question's about value-based care and how it's all about reward for quality care at a fair cost. So the essence is a risk-based portfolio management for human health. And the question here is, how do you see this impacting EMRs, billing systems, and your analytics?
I can take, this is Doug, I can take the first shot at that. I think where we see this is, to get very concrete, is in our hospital-acquired conditions. So we have an attribution model. Again, the whole problem within the hospital is somebody gets admitted, an attending gets assigned, and usually that attending is not responsible for the inpatient care, for most of that inpatient care. But if you know who saw the patient on which day, you can often use that to then go back and see who is responsible either for a lack of an event or for an actual event. And so what I see where this sort of leads is to becoming much more precise with providers and being able to give a much better insight in terms of that value-based care. I mean, you're not worried about generating the charge and generating the work review. You're worried about the outcome, like the readmission or the hack. So, I mean, at least that's my perspective on it.
Perfect. Thank you, Doug. And Chris or Stephanie, do you have anything else you'd like to add there?
No, I don't. I think that was a good answer.
Okay, perfect. So this next question here is about burnout indicators. Among providers, do you see a correlation between the use of scanning in the OR and fewer or lower burnout indicators? And I'll let anybody jump in here to answer this one.
Yeah, I guess I'd have to have a little bit more information on what they mean by scanning. I mean, does that mean, as a hospitalist, I'm not in the OR, but I'm presuming that has to do with identification and the need for not actually entering the data yourself?
We don't have any additional information on that right now, so why don't we go ahead and move to the next question.
Okay.
Our next question here is any of this data presented to physicians in real time to help guide practices, or is it reported out retrospectively?
Yeah, so
I can answer.
I'll take. Oh, go ahead.
Go ahead, Chris.
I'll let you start.
Okay. Well, we do. It is retrospective, but that retrospective can be a week. It can be every week. It can be. I mean, you don't want to do it too much, or it overwhelms people. But it certainly can be done on a pretty coincident basis. But from what I understand with Ingenious Med and what they're trying to do is to make it so the provider can pull it up contemporaneously. But I'll let Chris take it from there.
Yeah, that's what I was going to share, Doug, is obviously previously it's been retroactively with the reporting and some of the other things, but really we're trying to drive with the dashboards, again, one click away from the workflow that they've got to enter their charges in. As long as that awareness is there with what analytics and what capabilities they're looking at, we're hoping to drive that right at the point of decision, whether CPTs are moving in.
Perfect. Thank you both so much for that clarification there. Our next question here is about standalone charge capture. So for hospital physicians, won't standalone charge capture lead to more time in data entry and burnout? So Epic has a charge capture module. Can you provide any clarification there?
Yeah, that's fair, and that's definitely something that we that's definitely something that we address and a lot of our customers talk about. But really, when you look at a click-for-click comparison between us and the EHR, and specifically Epic, we really feel like there's a distinct comparison with Ingenious Med. And then you also add along the data analytics and reporting and the other indicators that aren't available within their particular charge capture module. I won't say it's an afterthought, but it is definitely just an add-on to everything else that the EMR is doing. And we are specifically and laser focused on that charge capture piece to make sure it's the most efficient as it can, and then really, that robust reporting on the back end. We've actually heard interesting kind of anecdotal conversations from our clients that mentioned, the data is really worth almost as much as the charge capture primary workflow as well as the other pieces. And then I'll also note, we've got we're one of the largest MIPS registries within the country. So there's definitely a lot of other aspects that we position to clients. So that's why we had said we really feel like we're an extension to the EHR. We're not a direct competitor, and we certainly have our own value proposition.
Yeah, and I can tag on to that too. I mean, I'll just start by saying that probably about half of our hospitals are Epic hospitals. And that's not something I hear from our folks. And I think that's partly because Ingenious Med is very sensitive to that, and as part of their business model, they can't be seen as causing more work for folks. So they really have simplified the way to get a charge entered with minimal effort. But the larger point, though, is that as much as it pains me, as a physician, I mean, physicians are not the center of hospitals. And I don't mean that in a bad way. They're just a big organization. And so, but at the same time, I need to manage my providers, and I need to give them the data so they can be managed. And if I go down to a hospital IT department and say, this month I need this, this, and this, please give me those reports, that takes a long time. And then, invariably I don't get the right reports. And I'm back down there in the next month saying, no, change it this, this, and this. And I don't, once that data is in the EMR, it's no longer something that I can control and interact with and produce the reports that I need produced. And I think having external billing data like that that's separate from the ER is beneficial just for that reason.
Absolutely. Thank you so much, Doug and Chris, for that extra clarity there. This next question kind of goes along that same train of thought here. So, Chris, you mentioned utilization as a key metric. From your experience, does the following statement resonate? If you just rely on your EHR or EMR to tell you what supplies you use during surgery, you're going to miss a lot. Does that resonate for you, Chris?
Following statement, if you just rely on your what supplies to use during surgery. No, I'm kind of struggling with that one. When we talk about utilization, we're really talking about the time and a number of different metrics like the length of stay and a few others, the volume, really, and you talk about RVUs per bill and a couple of other, how is the physician's time captured and monitored and reported back on, not necessarily what's in there about supplies in the EHR. So, to answer that question, I suspect, are you going to miss a lot? Yes. We're kind of outside of that over on the physician charge capture piece. So, we think about utilization in a much different aspect than I think this question is mentioning.
Excellent. Thank you so much. So let's go ahead and move to our next question here. What reports are available to non-physician care team members?
So we've got to non-care teams. So we've actually got a number of reports. There's our typical management reports. I think there's sort of 30 pre-populated reports that, depending on the administrator and how it's set up, either all the physicians can have access to it, and all of the non-providers can have access to it, or just the administrators. There's a lot of customization, as you can imagine, to the varying levels of access that we have. So, the short answer is everything that's available to the clinicians and more can be. What we usually do is shorten the amount of data available to the clinicians, because they're typically not diving into that. But we can, enable anything and all of the information that we have to non-providers, and really that opens it up to the BI platform as well. So, generally speaking, every bit of data that is available on our system can be extracted and compiled, put into a visualization in the BI platform. So, if you don't see something on a standard report, you can always dig in deeper with that BI platform and look for exactly what you want, with the time period that you want, and any other filters or exceptions that you'd like. So All of that can be enabled for any and all users on the platform. We usually dial it back depending on what the administrators want, but certainly it's something that we can enable.
Yeah, I'll just tag on to what Chris said, is that especially the BI platform, because invariably the non-physicians want more detail, I think, than the physicians may want. And, it's simply, it's not that difficult for someone moderately trained in these BI platforms to be able to pull out data for administrators. And so that happens in our office all the time, to non-physicians requesting data on how the providers are utilizing the care.
That makes a lot of sense. So as a follow-up here, can you talk about how you push out information from the platform, both to physicians and other non-physician providers?
I'll start. One is, as someone said, we generate the monthly and sometimes more frequent reports that are then sent to the providers by email. But something that's kind of unique, well, not really unique, because a lot of other platforms do this, you can set up subscriptions. So if we have a site where we're concerned about different levels of charges being selected at a particular site, we can send out every week, well, this is, to all the providers, this is how your group has performed, and this is how you specifically performed within each, compared to everyone at your site. So the subscription function works really well in that regard, and that's not just you can include utilization criteria. You can use anything like that. So you can, the risk is it's so easy to use. You can put too many in there, and then it becomes like alarm fatigue. People start just to delete as soon as they see it. So you have to be judicious because it's so easy to do. But there is a pretty cool function to be able to do that.
Yeah, thanks, Dr. Mitchell. Yeah, you highlighted the subscriptions, and then we've got the dashboards, which are one click away in an upcoming release. So that's a way to, it's not really push, but it's pushed out into the workflow. I'd also just highlight, kind of the initial or the individual data elements that are enabled within the platform on the mobile and the web version for, individual items as well, such as the flagging that I mentioned for specifically missing bills is a huge function, and obviously we're focused on that revenue integrity. So between the date of admission and the date of discharge, if we're missing a bill and we think it's out there, we can highlight it, flag it. The administrators can look at it and then push that over to the provider on their screen, so they can take care of that. So when we think about data elements, it's not just the analysis; it's also those day-to-day pushes that we can facilitate right in the hands of the physician as they're on their mobile device.
Excellent. Thank you so much. So our next question here is about charge capture. So we have an audience member who asks if the charges are captured directly within the system, and if so, how?
Chris, you want to answer that?
Yeah, I can take it. So it's a charge capture platform. So when we go in, the physicians, in a very short answer, are giving the diagnosis and then the coding associated with that. And obviously, we're receiving information on which patients are supposed to receive, potentially through an ADT feed or a number of other ways to get the information into our system. Typically, it's kind of populated so the physician can see all of their patients for that day, can sort and do their rounding, and then they're putting in that the diagnosis and the CPT code, and then that goes off to the billing. So we're that intermediate platform, but really where the kind of magic happens is that's available across anywhere. So we've got clients, such as Adfinitas, and they've got physicians all over the place in a number of different facilities. But there's that one charge capture platform. So when Dr. Mitchell wants to get his information on a particular site or a particular group, or at a macro level, it's all aggregated all the way up, no matter where they're providing the service.
Yeah, and I'll just add that the ease of entry, just a couple of mods that I've done. I mean, you can use your mobile device to do that. And then there's the hardest thing for charge entry is entering the demographics. But there's a functionality where you can actually scan the patient's barcode, and that'll automatically load the demographics for you if the provider is comfortable doing that. Some providers are a little uncomfortable scanning codes, but it works well. And then also there are linkages between some EMRs and the diagnoses. So the diagnoses may auto-populate, and then you could just delete the ones that don't apply to your visit. So there are functionalities that make it really kind of easy for folks.
Doug, as a quick follow-up here, or Chris, can you talk a little bit about how Ingenious integrates within existing EHRs?
Yeah, I'll let Chris talk about that.
Yeah, so I mean, typically it's through that the ADT feed. So as we bring on a new client or even a new site, whether we kick off a project here to pull in that information. So we work with the client site and pull in that ADT feed so that it populates and then does some pre-sorting depending on how the implementation is put in. So really that's the integration measure with the EHR. So they're two separate systems, but all that demographic information in most cases is brought over from the EHR so that the clinician doesn't have to do it in the charge capture, and we're not doubling down on that.
Perfect. Thank you so much, Chris. We have time for just a few more questions here. So this next question is, what kinds of programs does Adfinitas have to improve physician performance once it shows up in data? So that may be bonus incentives, retraining, et cetera. And Doug, I'll send this your way.
Yeah, it's a combination of all the above. I mean, there are financial incentives, though we don't have huge amount. I mean, there's different ways to get folks to improve. I mean, one is, just trying to instill a culture that goes to that, and then the other is sort of financial incentives. So that's it. I think peer pressure is really a big thing. I mean, if you can, look at one provider's cost of care compared to another provider's cost of care, and show other data that shows the case mix is the same, even though there's a big variance in cost of care, that's really a hard thing for people to argue against as long as they agree with the algorithm that came to that. So in a lot of ways, it's just putting that in front of their eyeballs and, explaining that obviously this is an important aspect of what we do as providers. And it is a quality indicator and reflects on the quality of care that you are providing. So, I think the transparency and then the accuracy of the data is really a very strong tool for motivating people to improve.
Excellent. Thank you, Doug. So as we start to wrap up here, Stephanie, Doug, Chris, are there any final thoughts you'd like to share with our audience today?
I can go first. I just go back to what I started with, man. I really think we have to start thinking about physicians, PAs, nurse practitioners as a workforce, and I say that in a positive sense, not as sort of widgets, but you have to manage them, and in order to manage them well, you need data that they believe and that you believe, and that's actionable. And I really think, if we're going to move towards value-based care, we can't just hope that it's going to happen. We're going to, as people who manage folks, we're going to have to be able to manage them there and meet them there. So.
Yeah, and Stephanie, I'd just echo Doug on that. I think we've seen over the years, right, we do a fair amount, if not a considerable amount of primary research and really talking to physicians. And not too long ago, we did a survey of independent physicians that really talked about data and access to data and linking it to performance. And clinicians respond well to data, right? It really helps them gain some clarity on how they're doing and how they're caring for their patients. The key is that they need to trust the data and have confidence in what they're looking at. So, really investing in the right solutions that capture data in the right way and translate it in the right way is really important to engaging those clinicians in the right way and really getting them to walk the walk about value and performance and, quality in the value-based care world.
Thanks, Stephanie. Yeah, I mean, I'd just leave it with that as well. When we talk to a lot of other clients, that's really the focus. I mentioned that reliability data aspect, and it definitely is the case. It's the case with a lot of people, but specifically clinicians. If you have a stack of information and they find one thing wrong with it, it's going to be a problem, and that lack of trust is going to be difficult to overcome. So we hear that from a lot of clients, and that's why they like our platform, again, because it's all user inputted data, so it's not pulling it from other places and sort of aggregating it, and some things get lost in translation. As Doug mentioned, here's where you stand based on the type of care that you're providing and the outcomes and what happens with that. So it's really that trust aspect with the data that's key.
Thank you. So that is all the time that we have for today. I would like to thank Stephanie, Doug, and Chris for their excellent presentation, and Ingenious Med for sponsoring today's webinar. To our audience, please enjoy the rest of your day, and we look forward to having you join us for future webinars.